So, basically this is sort of just meant to be a review of what a lot of you guys have sort of learned about, in the sim lab during cycle 2, right? So obviously you guys are all thoracic ultrasound experts. So I just wanted to take this time to do a quick review of what you guys learned back then, and then also maybe add a couple slides and some additional findings that you can use thoracic ultrasound to help diagnose. And then we're going to probably finish up with a series of cases, both real and sample cases, to try and quiz you guys a little bit. And so if you guys want to, comment in the chat if any questions come up, or if I'm asking any questions, just feel free to stop me or speak into the mic, whatever. So with that, we'll get started. My computer's very slow. Bear with me. Hold on, let's see here. I hear the music going crazy. Hold on a second. Hold on, let me get out of some of this stuff. Sorry.
If it's still not working, you can always send it over.
Okay, let me, let's see. All right, now? All right, good. All right, so basically, obviously just to start with the basics, we need to review proper technique, right? So for thoracic ultrasound, you really want to use either the body or the vascular probe, depending on what you're looking at. So if we're looking at the typical lung views, the body probe is adequate. The benefit of this is that you can evaluate things at greater depths. If you want to pay close attention to the pleura or anything more superficial, then the vascular probe might be your probe of choice. And keep in mind for both probes and for all abdominal thoracic ultrasound, the probe marker should always be facing up. And this will correspond to the left of the ultrasound screen. So just keep in mind that left is cephalad, right? And then a complete lung ultrasound exam, you ideally want at least 2 anterior views, at least 1 mid-axillary view, and ideally a posterior or flaps view. So at least 4 views per hemithorax. You can go up to 6. This is just sort of a snapshot of, the types of areas where you want to look, right? So if you do anterior views, both up towards the, second, third intercostal space, and then a couple rib spaces down, you can do 2 mid-axillary spaces, and then you can do a posterior view, which is almost mid-scapular. So of course, when looking at normal lung anatomy, right, in order to get your ideal view, you need to place the probe within the intercostal spaces. And this is going to help you visualize the pleura and then the underlying parenchyma. And on lung ultrasound, right, the pleura is going to be this bright white hyperechoic horizontal line, and it's going to be immediately below the soft tissue. Depending on where you are, the patient might have more soft tissue than not. So it may be 1 centimeter, maybe 2, 3, 4, 5 centimeters, depending on the view. But this white horizontal line denotes the pleura, and it's really the 2 layers of the pleura that are sliding up against each other in normal aerated lung. This is a classic view of a normal A-line pattern of lung, right, where you have the pleura and then the horizontal A-lines below the pleura, and then you have these areas of darkness, and this corresponds with the rib shadow, right? So obviously, if you remember, bone is bad for ultrasound, so after the ultrasound hits the bone, you're going to get shadowing immediately distal to it. So, depending on whether the patient's cachectic or not, may have trouble going in between the intercostal spaces, but ideally you should be getting a view similar to this. This is just another visualization of the same view, but using the vascular probe, where you can appreciate the superficial tissue a lot more clearly in the superficial depths. And then the pleura is this bright white line, which is denoted by the white arrow. And then the black shadows correspond with the rib. This is just showing the spectrum of typical lung findings, right? So the picture on the left is going to be your classic A-line pattern, where you have the pleura, and then you have the parallel horizontal A-lines as you go deeper and deeper with your view. And then these are just a spectrum of B-lines, right? So this starts with just maybe 1 isolated B-line, which could be considered normal depending on the clinical scenario. The patient might be lying in bed. There's maybe a tiny bit of atelectasis, which is, if we ultrasounded ourselves in our bases after lying down for a few hours, I wouldn't be surprised if many of us had, at least 1 B-line in that lung field. And then as we get into the more abnormal findings, right, you have more than 3. I think this snapshot, there's about 5 B-lines, and then you have all the way on the right, more confluent B-lines. And so basically, what does A-lines represent again? So A-lines are just your hyperechoic horizontal lines, equidistant from the pleura. And this is indicative of a normal aerated part of the lung. Once you get to the B lines, as opposed to the A lines, which are horizontal, B lines are vertical, and they extend the entirety of the depth of your screen. And these represent, if there's just isolated 1, 2, 3, it's likely related to thickened interstitium, or thickened interstitial space. And again, they will move with the sliding lung, with the pleura that's sliding as well. So you might see it move in and out of your view as the patient's breathing. If you see more than 2 B lines, so 3 or more, that's abnormal, and that's going to obliterate the A line pattern. And then as you get into more denser, more diffuse B lines, this would actually correlate potentially with what you might see on CT as ground glass opacities. This is just highlighting the variable findings you might see in your PLAPS point. And again, the PLAPS point is your posterior lateral alveolar implode syndrome point. And so this is localized to the lower lobe of the lung, and it commonly is going to be in the posterior aspect or almost even mid-scapular area of the back. And this is going to be your most common area for finding if there's pleural fluid or lung consolidation in the lower lung fields. And so this is sort of just a spectrum of what you might find when looking at the PLAPS point. If people want to comment, what are we seeing here on the left? What is this finding called?
Curtain sign.
Excellent. Yeah. So that's going to be your classic curtain sign, right? And you can even appreciate whether it's whether there's B lines or A lines when the lung's sliding in, but in this case, it's a nice normal curtain sign. What are we seeing in the middle?
Effusion.
Yeah, yeah. A pretty large pleural effusion, right? And then what are we seeing on the right?
Hepatization.
Yep. And what might that indicate?
Lapse of the lung, like atelectasis.
Yeah, it could be atelectasis. What else might it be?
Consolidation.
Yeah, consolidation.
Yeah. Could it be indicative of pneumonia consolidation? So yeah, we'd sort of need to look a little bit more closely or look at the clinical picture to determine what specifically is causing that finding, right? So this is just highlighting whether the difference between lung sliding versus the absence of lung sliding. So if we want to just take a look, right? So on the left of the screen, right, you can see nice lung shimmering, right? So the pleura is up here with some A lines below it. And there's a nice little shimmering of the pleura, as opposed to the image on the right, which there's maybe some movement related to the heartbeat and the operator with the probe, but there's no shimmering at the pleura, right? So this would be indicative on the right of an absence of lung sliding. And when you see an absence of lung sliding, what is on the differential?
Patient is dead.
Yeah, absolutely, that could be a possibility. And so maybe depending on what else is going on, you might want to call a coach or what else?
Pneumothorax.
Yeah, pneumothorax, absolutely.
Like pleurodesis.
Yep. Yeah, so if there's no movement, basically, if the pleurodesis is right where the pleural lining are permanently attached to or adherent to one another, right, you're not going to get any lung sliding. What else? The only other, main thing to think of is if there's no, if for whatever reason that area of the lung is not getting aerated, right? So if there's a reason for atelectasis there, if let's say the patient has a right main stem intubation and you're looking on the left, you may not see lung sliding because there's no movement of the visceral pleura with respirations in that situation. All right. All right, this next slide will look familiar to anyone who did cycle 2 of the SimLab. So this is our lung point, right? So this is our transition point between the absence and the presence of lung sliding. And as opposed to when you just see an absence of lung sliding by itself, this finding is pathognomonic of a pneumothorax. And this, why is it important? It's important to not only prove that there's a pneumothorax, right? But most pneumothoraces, depending on the clinical picture, right, might need to be intervened on, right? So this is helpful to delineate the extent of the pneumothorax, where we would potentially put a chest tube in, right? We wouldn't want to damage any normal lung, right? So we want to put a chest tube in the area that would be the highest yield to resolve the pneumothorax, right? So it helps us with our procedural accuracy. If you're not sure, let's say if you're not sure whether there's lung sliding or not, like what's another tool we have that can help delineate the presence or absence of lung sliding?
M mode?
Yeah, excellent. And so what are we looking for specifically on end mode? Like what are the classic findings?
Seashore sign.
I'm sorry, Athena?
The seashore.
Yep, seashore, yep. And then so the seashore sign means what?
There's lung sliding.
Yep, okay. And then what it would be the absence of lung sliding?
Like the bar,
What was that, Eric?
the barcode sign.
Barcode, yeah, excellent, excellent. All right, so this is, I mean, you guys already know this based on, our discussion right now, but this is just for catching everyone else up to speed. So seashore sign, essentially, why is it called the seashore, right? So you just imagine the sub-Q tissue with end mode under specific lung view, right? The sub-Q tissue sort of represents sort of the waves crashing in. The pleura would sort of be like the coastline, and then the normal aerated lung has a granular appearance, which resembles sand, right? So your normal aerated lung is sandy, sandy appearance or seashore. And then as opposed to the instance of a barcode sliding where there's no lung sliding, right? You sort of just have the sub-Q tissue, which isn't moving, right? So it's just complete straight horizontal lines. The pleura isn't moving, it's a straight horizontal line. And then you're not seeing in between the pleura or beyond the pleura, right? So you just get these horizontal reflections that are not changing over time. And that's why you're getting a barcode sign. I just also wanted to include this to highlight the overall the varieties of pleural effusions, right? Obviously, not all pleural effusions are created equally, right? So we have on the left a nice simple appearing pleural effusion, and on the right is a gross complex loculated effusion. You can make out, right, the fluid pockets here, but with all these septations. And this might be indicative, depending on the clinical scenario, of an infected pleural space. And may require a chest tube or some other intervention to help relieve and clear out all this adherent fibrotic and pus-like material. Sometimes we always get asked on ultrasound, how do we estimate the pleural fluid volume? And I think it's tricky a lot of times, but in the literature, there is a couple things that are described. And so one of the ways to do it is by looking at the most cephalad aspect of the diaphragm. So like right here, and measuring the distance to the nearest area of lung in millimeters. And that distance in millimeters times 20 is a potential estimation of pleural fluid volume. But that's, that's not to say there could be additional pleural fluid that's tracking up or hiding elsewhere, but so that's just a rough estimate. If you're wondering, okay, is this worth tapping? Is this over a liter? Is this something that's potentially causing symptoms? That's one way to calculate it. All right, so I know obviously there was a clip a little earlier about lung hepatization, and then we mentioned whether things are could be consolidation or pneumonia versus atelectasis. So one of the key ways to differentiate that is by looking at the air bronchograms within the consolidation, right? And so I sort of listed it here. I was going to ask you guys questions, but so if you see something like a static air bronchogram where there's not much movement of the bright white spots, that sort of delineates that there's not air going in and out of that space. And so that might be indicative of something more like along the lines of an atelectasis picture. And that's in comparison to this on the right, where you have movement of the white spots with respirations, right? You can see it right here with my little hand pointer here, moving with respiration. So that's going to be more indicative of an infectious process, or an alveolar filling process, where the airways might be aerating or going in and out with respirations. And so you're going to get what's called dynamic air bronchograms. So dynamic air bronchograms are more indicative of a pneumonia or infectious process, whereas static air bronchograms are more indicative of an atelectatic process. And if anything doesn't make sense, please stop me, please interrupt me. I just wanted to include this additional slide on some of the other lung ultrasound findings, which I don't think we talked too much about during the sim cycle 2. Has you guys heard about the shred sign? So the shred sign is basically commenting on the shredded appearance of lung that's distal to an area of consolidation. And that's basically just resulting from how the lung interacts with that interface, right? And so this is what you'll see in a patient who has subpleural consolidations. And it represents the boundary between that consolidation and normal aerated lung. So if you see here, right, so this up here, it's hard to tell like what this is really, right? It could be, is this fluid? Is this complex fluid? Is this hepatization of the lung? I think this is the diaphragm right over here. But I can tell that this is probably a subpleural consolidation because we have this shredded like hyperechoic line right below it, right? So this would be indicative of a subpleural consolidation with a shred sign here. And then notice below it, you have B lines and you have sort of a grainy appearance. So this would be the border of the consolidation right here. And then this is highlighting what's called lumpy bumpy or fragmented pleura. And so this is useful in patients who have B lines in a specific lung view, or they may have B lines diffusely. And this helps delineate cardiogenic edema from non-cardiogenic edema, right? So cardiogenic edema will have nice smooth pleura throughout with diffuse B lines, as opposed to something where it's lumpy or bumpy, fragmented. That'll be more indicative of the non-cardiogenic picture, whether it's inflammatory or infectious. And so this would be an example of a patient with a fragmented pleura, right? You can kind of see there's something down here, then it goes up here, then it goes down here a little bit. Its area is thicker than other areas. And then there are B lines, right? So this would be, if we saw this, I would say that the B lines are not from cardiac or cardiac causes. And I would think about something else going on, whether it's pneumonia or an inflammatory process. Any questions about these two findings? All right, so we sort of raced through that quick lung ultrasound review. I think what we're gonna do next is sort of just run through a series of cases, and it's really just 5 cases, and we're just gonna walk through them. You know, depending on what you guys think of the images, you may get them pretty quickly or not. Some of these are real cases that we've encountered on the ultrasound elective, and some of them I had to make up. So if they don't make sense, I apologize. It's just, I didn't have a vivid imagination, but maybe I can tweak them for the next one. All right, so let's go to the first case. So case 1. So in this situation, we have a 32-year-old man with past medical history of end-stage renal on dialysis, type 1 diabetes, and hyperlipidemia. So it's an unfortunate case. He came in with acute onset change in mental status, and he was ultimately found to have anoxic brain injury in the setting of what was presumed to be a severe hypoglycemia and likely a prolonged seizure event. He had a poor neurological recovery and underwent the trach and peg earlier in the hospital course. And then the on-call team, you know, several days later into the hospital stay, was called to his bedside in the setting of worsening respiratory stress and mild hypoxia while on trach collar. On his exam, on his physical exam, you know, we do still use stethoscopes, even though we have our ultrasound. It was notable for diminished breath sounds on the left, and he was tachypnic with use of accessory muscles. And so the medicine team knew that the ultrasound residents were eager to get some extra practice, so they called them to the bedside to help determine the cause of the change in his clinical status. Any questions about the history before we get to the images? Already thinking of what could be going on with the patient. So this is his right side. So the clip on the left represents the right anterior lung, and the clip on the right is sort of the right mid-axillary / posterior area of his lung. So what do you guys think? What are we seeing on the first clip? Okay, so I'm seeing some B lines. Anything else? So this one, I think, the anterior finding, he does have some, obviously this is the pleura here, and then you see some thin B lines coming out, but you can still make out some of the A lines, right? So I think, I would say the anterior space at least looked closer to normal for me, because you can make this out here, and you have to sort of imagine that there's an A line a little bit distal. I was more impressed with what we're seeing on the right, right? So on the right side, you have, this is a curtain sign, right? Because you have the liver here. And then if he takes a breath, you can see the diaphragm, and then there's the lung coming in, and the lung that is coming in, it has more diffuse B lines. Even though you're still able to make out some of the horizontal A lines, the B lines definitely predominate when you get down to the right base. Right. So that was on the right, and then now, obviously on the physical exam, the left side was what was of interest. So let's see what was going on the left. All right, and so the left is going to be the left anterior space, and then the right clip is going to be the left mid-axillary space. And these are real ultrasound elective views, so they're not A+ views, but they're definitely more than adequate to in terms of make our clinical assessment. So what are we seeing here?
Hepatization of the lung.
Yeah, definitely. So you can kind of, this is kind of confusing over here, right? Because you're like, if you're in the second, third intercostal space, like why are we seeing potentially what could be diaphragm already, right? Or below the diaphragm already, like a spleen or other abdominal structures. But you can kind of guess we're in the thorax because you can see something beating pretty quickly right here, right? So this is the heart structure. And then maybe the potentially right near it is if this is directly next to the heart and we're not near the diaphragm, this is potentially a large lung hepatization. And then on the clip over here on the right, you can make out the difference a little bit more distinctly, right? This is the diaphragm here. Because even though you have some lung hepatization, there's a little bit difference in terms of the texture and the coloring between what's likely the spleen, which is down here, and then above the diaphragm, which is all lung consolidation. So concern for pretty extensive hepatization of the left lung.
I have a question. Can you see air bronchograms on the first picture on the left?
I would say there's potentially air bronchograms. Do you see where my hand's pointing here?
Yes.
Yeah, probably
that's where
down.
I was at.
Yeah, probably right down here.
Oh, thank you.
Yep. On this clip down here, I'm not really seeing anything super bright hyperechoic, so it'd be hard for me to comment what might be going on down on this view, but potentially here, there's some movement, but it does, it's hard to say because the heart's like beating against this area really fast. So is it moving because the heart's beating against it, or is it moving because there's lung aerating through? So I'd be pressed to really confidently say whether this was related to something like a pneumonia versus atelectasis. I'd sort of have to rely on the clinical picture more than anything else. But definitely, if this would be quite an impressive pneumonia for it to be taking over pretty much the entirety of the left lung, right? In someone who's a trach patient. So with all this in mind, like, what do you guys think is going on, and what should we do next? Anyone?
Is it possible that the patient aspirated because of acute decline in the status?
Yeah, definitely possible aspiration pneumonia, right? The question is whether or not we should start antibiotics. If he's not on antibiotics, if he's looking uncomfortable, febrile, right? If this is, atelectasis or even pneumonia, what else could we potentially do that might help the patient? So I see ordering a chest x-ray. Yeah, absolutely. I would still order the chest x-ray, even though we ultrasounded the patient. Yeah, increase FiO2 too, right? Yeah, definitely if he's uncomfortable appearing, right? The oxygen sort of borderline in the low 90s. I would definitely increase the FiO2, absolutely. If we think this is, let's say if this is atelectasis, right? Well, what might we do? Or what might also help the patient?
Increase PEEP.
So I would potentially, I will say he was just on trach collar. So he wasn't on any vent support or positive pressure. All right, so Christopher's saying chest PT. Yep, I agree. I think if something like this, and even if it wasn't ammonia, chest PT might be helpful just in terms of shaking up any deep secretions, right? And what else potentially would be helpful? So I would say, probably something that we don't necessarily do too much on the floor, but maybe would help is like a deep suctioning, right? Like nasotracheal tracheal suctioning, trying to, if it is something like a mucus plugging or deeper secretions, right? Really going deep to try and suction out whatever might be stuck down there. So this patient did get an X-ray, so we can show you what the X-ray showed after our ultrasound view. All right, and what do you guys think? Does this sort of support, go against some of our diagnoses?
I think it supports in a way, but not like all the way, only because there's you can see the left side actually, you can see obliteration of costophrenic angle, which might suggest pleural effusion as well, which we did not see on the POCUS.
Yeah. So it's interesting, right? Yeah. So if you had just done this before you did the POCUS, right, you have a broader differential where this could just be a complete white out of the lung. It's probably a large pleural effusion, right? Other things I would point to, obviously this isn't like a radiology lecture, but the carina is probably over here, so maybe there's a little bit of shifting of mediastinal structures towards the left, so that would maybe delineate that maybe there's some volume loss here. So potentially this could be white out from atelectasis, where there's complete collapse of the lung. You can also maybe try and see so that you can make out the right main airway here, and then potentially the left airway goes here, and then there's like a little bit of a cutoff here. So to me, this would maybe be suggested that there may be some mucus or something that's obstructing most of the left main airway, and that's maybe leading to atelectasis of the entire left hemithorax. So basically, this patient was underwent chest PT, was aggressively suctioned. They also adjusted his PEG tube feeds in case that there was maybe some element of aspiration, and he sort of improved. And they ended up still treating him with antibiotics just in case. But the working diagnosis was atelectasis from mucus plugging. Yep, yeah, sure, I say mucus plug, yep. All right, going on to case 2. This is another real case. So this is a 46-year-old man. He has past medical history of polysubstance abuse and metastatic lung cancer with a known malignant effusion. He underwent a left-sided Pleurex catheter placement a few weeks ago, who now comes in with from the oncology office with shortness of breath and weakness. Initial workup was notable for bilateral pleural effusions. He had the left side drained earlier in the hospital stay. He also had a large pericardial effusion and underwent a pericardiocentesis. And then he actually received a round of inpatient chemotherapy. So he's been here a long time. The primary team is now getting calls because he has new fevers, tachycardia, and mild shortness of breath. All right, and so this is the left mid-axillary. What do you guys think? So some concern for consolidation. Yep. I mean, there's something, I will say all of this looks kind of weird to me, right? So what's down here is probably the heart, right? And I'm not really seeing if we're above or below the diaphragm because I can't really make out the structures too clearly. But I'm seeing some areas of anechoic or black, right, with some areas of consolidation, or whether it's fibrinous material, it's hard to say, right? But I think anytime you sort of see like this area, like down here, over here, there's like some black, over here, there's some black fluid, right? Even here, there's some black fluid. And then there's like maybe, could be hepatization of the lung, could be fibrinous inoculations. So this would be confirming for an infected space. Someone who has chronic effusion and now maybe there's been some type of infectious process going on. Does that make sense? I think maybe part of the diaphragm is coming in over here, but we're not getting a great look because I think there's unfortunately a rib shadow right here. And just to compare the left mid-axillary with the right, so this is what we found on the right. So what do you guys think here?
Is that the long point? Like there's a flap and also an effusion.
Yeah, so this is going to be a confusion, not confusion, a fusion here, right? You see this effusion here. And then this is sort of a little bit of curtain sign where there's a lung sliding in over part of the effusion. So it's probably like a not, you know, for it to be, if you're trying to quantify the size of the effusion, right? If you're able to see some lung sliding into your view, it's probably not a super large effusion. And then there's some area of like associated lung consolidation. You know, it's hard to see. I think honestly, this view is a little overgained, right? Because you see how bright white some of this lung is. So that's probably overgained. And that I think is why this area looks a little bit grainy than the top part. But I actually think it's probably a simple effusion. Just that this is probably some artifact from the overgained image. So with this in mind, with comparing the left side to the right, like what do you guys think is going on? And then what should be done? Yeah. So drain the effusion for sure. And then if there's concern for, and how do we want to drain it, I guess? So keep in mind the area on the left that we were looking at, there's an indwelling pleural catheter there. Yeah.
Tube and then break up if there's a tube there already, it's not draining what's there. You might need to take out that tube and maybe inject something to break up the fusion there.
Yeah, absolutely. Because, you know, and now that he's like febrile, right? So he's had this indwelling pleural catheter in, the effusion definitely does not look normal. So I think, yeah, if it's not draining anything really, it should, regardless with the new fevers, it should come out. And then from there, you might want to proceed with either, oh, there we go, like a VATS versus chest tube and like lytics to try and, you know, shake up the fibrinous material and get some of the extra pockets out. So definitely the indwelling pleural catheter would need to come out, and then probably consulting at the very least thoracic surgery for further assessment. Just to show you guys, so this is what the X-ray subsequently showed, right? So this right side is what correlated to what we were seeing on ultrasound with like a small to moderate effusion, right? You see sort of the disappearance of the costophrenic angle here, right? There's also probably some vascular congestion. And then on the left, there's also a pleural effusion, and it's pretty loculated because it tracks all the way up to the very top of the patient, right? This area of white is fluid. And then you can see the IPC going in here and like really hanging out in the base. And then this is just a snapshot of his CAT scan showing the right effusion, which we saw on the ultrasound, right? Small, more simple appearing compared to the left, which is very loculated. Like normally if the patient's lying flat, right, it should be gravity dependent. So the fact that it's just hanging out on the lateral aspect signifies that it's loculated, and when it's automatically loculated, that's something that would require probably a chest tube to help drain. And so this patient ended up getting the IPC removed, a new chest tube placed with lytics only. He wasn't a patient who was a good candidate for VATS. That's why they sort of elected to do chest tube alone instead of VATS. All right, so the next case is case 3. So now we have a 72-year-old woman. She's recently diagnosed breast cancer. She's coming in with several hours of worsening shortness of breath with exertion. She has a temperature of 99.8. She's tachycardic to 112, blood pressure is 108/60, respiratory rate's 24, and she's satting 92% on room air. She's placed on nasal cannula for oxygen support. She started on empiric vancomycin cefepime for possible pneumonia, although the chest x-ray and the ED was read as clear. And then she's admitted to medicine for further workup and management. And of course, all of you guys are very knowledgeable and eager for her ultrasound. So you decide to bring an ultrasound to the bedside to see what's going on with the patient. So this is what we found on the right. So what do you guys think? What are we seeing here? So on the left is the right anterior space, and on the right is the right mid-axillary space.
The first image looks normal with A lines.
Yep, I agree. A-line pattern, and then on the mid-axillary view, what do we think?
There's like only one A line I can appreciate.
Yeah. Yeah, and then we're trying to maybe we can see one quick B line that comes in. So we're not really making out much A lines, but we're not really seeing confluent B lines or like more than 3 B lines, right? So it's likely normal curtain sign. And so this is on the left. It's not playing. Let's see. Okay. What do we think of the left lung findings?
It also looks normal.
Yeah, I agree. So definitely A-line pattern here on the left, right, for the anterior spot. And then this is a nice curtain sign where you have the lungs sliding over the spleen. So normal A-line pattern throughout the bilateral lungs. And a patient is tachycardic, short of breath, and mildly hypoxic. So with that in mind, what do you think is going on with this patient? And then what's on the differential in this type of scenario?
I would consider PE.
Yeah, PE, absolutely, right? I mean, she has a newly diagnosed breast cancer, so she's tachycardic, she's mildly hypoxic. What else maybe could be on the differential? Just maybe like 1 or 2 other things. So really the only other thing is probably some type of a patient with obstructive lung disease, whether it's COPD or asthma, right? They might be in an exacerbation without having like a focal consolidation as a cause of the exacerbation. Usually, obviously, if that's the case, you would find or hear wheezing most likely on physical exam, but it's something that also can mimic a normal A-line pattern when you ultrasound the patient. So those are really the main considerations, PE or COPD exacerbation. So what would you like to do or order next? Yeah, CTHS, absolutely. What else? All right, yeah, absolutely. I mean, you're already there, right? You might as well just look at the heart too with the ultrasound. Yeah, a chest X-ray, good. All right, so we did all of those things, right? So, oh, and sorry, any lab work or anything that we should have ordered that maybe wasn't done? Yeah, yeah. Troponin, BNP, excellent. I think you guys covered everything, right? So the patient ended up having negative cardiac biomarkers. We did do a bedside cardiac ultrasound, which I'm not going to show because we're probably going to do it at a future date, right? But essentially it showed normal LV function. There was no obvious RV dilation or dysfunction. That being said, she did have a CT angio chest, which showed bilateral segmental pulmonary emboli. And then she additionally subsequently had a lower extremity DVT study, which showed a right common femoral DVT. So based on these findings, she had negative cardiac biomarkers and no RV dilation on imaging. So she ended up just getting started on therapeutic dose anticoagulation and was just discharged within 2 days of hospital stay. All right, case 4. So we have an 86-year-old man, past medical history of hypertension, hyperlipidemia, COPD, diastolic heart failure, and CKD. So quite a typical elderly gentleman with a lot of medical issues. He came in with shortness of breath and unintentional weight loss. His workup in the ED was notable for left pleural effusion on chest X-ray. And so the pulmonary team was consulted and he underwent a thora where 1.6 liters was removed and the fluid studies were sent and are currently pending results. He was then admitted to the medical floor. But during the evening nursing assessment, he was noted to be pale, diaphoretic, and short of breath. So the nurse tried to page the resident, but didn't get a response right away. So she just called a rapid. And upon arrival of the critical care team, the initial vitals were this. So the temperature was 99.2, heart rate was 124. The blood pressure was 90/52, respiratory rate was 22, and the O2 sat was 91% on room air. Thankfully, obviously the on-call ICU intern here at Mount Sinai West came with a fully charged portable ultrasound. Which was a rarity because the batteries never seem to be charged or working. But this is what we found. So on the right, so what do you guys think on the right?
Looks normal.
Yep, very normal, right? So this is an A-line pattern anteriorly, and then this is a nice view of a curtain sign with, again, A-line pattern. So right side's normal, but the left side is where they did the tap, so that's probably the one that we really care about. So let's see what the left side shows. What do you guys think? So what about, this is the left anterior. What do you think of the left anterior spot?
Looks normal on the anterior part.
Yep. And then what do we think about here? I'm seeing. Yeah, so I mean, the main thing here is trying to identify any structures, right, that we can. So I would just point to the fact that this curvilinear structure that you're kind of seeing here is the diaphragm, right? And then this here is probably intra-abdominal. So probably seeing the tip of the spleen here. So that means all of this is something that's there when lungs should be there. And, like we guys are saying, this is not classic of like a typical simple effusion, right? Where you can kind of see some anechoic black up top, right? And then as you get deeper, there's like movement of stuff. I don't know if this is debris, but there's a gradient, right? Where you have black to sort of dark gray to lighter gray towards the bottom, right? Yeah, so when you see this is a hemothorax. Yep, this is hematocrit sign, yep. So this is something very rare that you probably shouldn't see, hopefully, right? But it's something that would be very concerning in this patient who's potentially hemodynamically unstable and decompensating. So this patient ended up having a left-sided hemothorax post-thoracentesis that was done in the ED. So with that in mind, what would we do next? Any additional workup or consults that we should be calling? Yep. Yep. Coax, UC type and screen. Yep. Yep. Cardiothoracic surgery. Absolutely. Yep. So this is something, for hematocrit sign, this is not something that a critical care person typically can do on their own, right? This would require, depending on the acuity, right, and what the effusion looks like. If there's any, like this one had a true hematocrit sign, it'd be very hard for us to adequately drain some of the older blood out of that pleural space. And so this is some patient who would potentially at the very least require a surgical chest tube, right? And we would need to aggressively resuscitate them. And then there would need to be a way to try and stop any bleeding, right? So depending on what was causing it, classically in an elderly patient who undergoes thoracentesis, it's usually related to an intercostal artery that's getting nicked. So you may, in addition to calling cardiothoracic surgery, you may want to also call interventional radiology. And sometimes it could embolize some of these arteries to stop the bleeding. But definitely you need to treat it as if it's like a patient going into hemorrhagic shock, even in enacting a massive transfusion protocol. All right, and then we're just going to race through this final case. So we have a 57-year-old with past medical history of hypertension, hyperlipidemia, diastolic heart failure, probably substance abuse, alcohol, opiates, tobacco. So he's coming to Mount Sinai West after he's being found down in Port Authority. In the ED, he was initially drowsy. He was mildly tachycardic, but otherwise had unremarkable vitals and lab work. A UTOX was pending. And then while he was hanging out in the ED, several hours later, he became acutely diaphoretic and developed respiratory distress. At that time, vitals were checked. His blood pressure was 192 over 104. Heart rate was 130s. Respiratory rate was 28, and he was satting 87% on room air. There was concern that maybe the patient, on top of everything else, had aspirated. And so while placing the patient on oxygen support, we decided to investigate his change in clinical status by using our ultrasound skills. And so this represents the right side. The left clip is the right lung anterior, and the right clip is the left lung anterior.
Lots of B lines there.
Yeah, diffuse, right? And would you say they're both equal sides, or yeah? It's really big. Sorry, yeah. Yeah, I mean, they really go like the extent of the way down, almost like the bottle rocket sign, right? So where you get pretty diffuse, confluent B lines, you can't even really count how many B lines there are. So definitely in the anterior lung fields, it's confluent B lines. And then we looked at the bases as well. What do we see here? Oops. What do we think? Yeah, B lines throughout, right? So I'm trying to reflect, show, the curtain sign here, right? So this is on the right, this is the liver and the kidney. And then you have, with the curtain sign, B lines coming in, right, diffusely. It's important there's like, what don't you see here, right? You don't see very large effusions, right, on the right. I would say on the left, so this is a sample case, so it's not perfect. I struggled to find a curtain sign with B lines. So there is some fluid here, if you notice, in the abdominal space. So you have to use your imagination and pretend that that's not there. But this is, this would be sort of ascites around the spleen, right? Because this is the diaphragm here, and then this is the curtain sign coming in, and the curtain sign that is coming in is associated with B lines. So the main finding with this lung view is B lines diffusely, right? So based on his clinical scenario and what we're seeing on ultrasound, like what is the most likely diagnosis?
Acute pulmonary edema from the hypertension.
Yeah, absolutely. Yep. And what else could it be, I suppose? And how would we use ultrasound to differentiate it from other things?
So we can check the pleura to see if it's cardiogenic versus non-cardiogenic pulmonary edema.
Excellent.
If you see like the shred sign.
Yeah. Oh, sorry. So shred sign is going to be for subpleural consolidations. It's called lumpy bumpy or fragmented pleura is what we're looking for. It's very scientific name, lumpy bumpy. But basically, if the pleura looks very irregular, not smooth like it should under normal circumstances, that would be more indicative of a non-cardiogenic pulmonary edema picture. In this patient, yeah, we only had the body probe, so we couldn't really look that closely at the pleura. But for the purposes of this case, I would agree the most concerning diagnosis or most likely diagnosis would be acute pulmonary edema from the hypertension. And I guess how will we treat this patient? If this was an RRT, what would you want to do?
Raul, do you want to share what your treatment plan would be? Sorry to put you in the spot.
Huh? Yeah.
Diuresis.
Yeah. Okay. So diuresis, I'm seeing IV nitro, chest X-ray troponins. Okay. What else? How would we help their respiratory distress potentially?
He could beneficiate from BiPAP.
Exactly. Yeah. Positive pressure. Yeah. I think, and it can even just be CPAP, right? I think as long as you have the positive pressure trying to push out the excess fluid out of the lungs, that would be preferable. Yeah. So absolutely, if the patient's in respiratory distress, you can strap them on BiPAP, diuresis, start nitro if needed, and then get the further workup. Excellent. So really that's all I have. Are there any questions about, I think you guys are beyond experts now in lung ultrasound, but are there any lingering questions you might have about what we talked about today or lung ultrasound in general? Yep, thank you, Sani. I put it on the PowerPoint, but that's the direct link to Focus Corner on the Chief website. All right, I think with that, then we can probably end for this afternoon. I don't know if you have anything after this.
We'll have afternoon report, but thank you so much, Dr. Rothman. That was an excellent explanation. We'll see you next time.